Hi everybody, it's Melanie. I'm going to run you through a brief PowerPoint here highlighting some of the information that would be good to know if you're ever taking care of any pediatric patients with respiratory compromise or needing some higher level respiratory type assessments and or treatments, skills, that sort of thing. What we're really looking at here is just a small piece of the McKinney textbook, chapter 37, more specifically pages 842 to 846. So it's not a large, obviously not a large chunk of your textbook that's involved here, but it's still important information that you might need to put in your back pocket for someday when you're taking care of pediatrics. This is going to concern your specific role as a registered nurse. It involves some more advanced assessments than probably what you're used to. And the goal here is, particularly with children, because from a respiratory standpoint, that's usually what's compromised and um, um, what am I trying to say? Goes into a downward spiral. And then that leads to cardiac compromise in pediatrics. So your job is to pick up on subtle changes that you're seeing in the child and then intervene appropriately so that that cardiac compromise, it never even gets to that point. It just stays from a respiratory standpoint. And that's usually much more manageable because the child isn't quite as in such a bad situation if you can catch it early instead of later. So oxygen therapy, there's a number of different ways that we can administer oxygen to children. Nasal cannula, keeping in mind that you're maxed out at 6 liters via nasal cannula. We also have the option of a Venturi mask, and that's pictured here on the slide. It can deliver specific concentrations of oxygen. They come in different colors, they're color coded. Venturi masks do have a minimum flow rate of 4 to 6 liters per minute, and that's just to prevent rebreathing of exhaled CO2 on the part of the child. There also is what we call a simple mask. A simple mask can deliver anywhere between 35 and 60% oxygen at a flow rate of 6 to 10 liters per minute. So you have a little bit more of a spectrum there that you can use as far as oxygen delivery. We also have a partial non-rebreather mask that can supply 50 to 60% oxygen at 10 to 12 liters per minute. And then a full non-rebreather mask can supply close to 100% oxygen at 10 to 15 liters per minute. Now, these aren't necessarily decisions that you're going to be making as the registered nurse. You're obviously going to be applying the oxygen therapy with your respiratory care counterpart, and you're going to be following your provider's prescriptions. But it's also good because you're going to be the one assessing the child and monitoring them for improvement or de-escalation. You're going to be needing to know, kind of the rationale behind the oxygen therapy that's being delivered. We also have, and I mentioned already, a high flow nasal cannula. You can go this route if you're wanting to avoid a trach or a ventilator. Obviously, it's going to be humidified flow. Sometimes it's heated. It also has BiPAP features, positive pressure that's at the end to keep the airways open. You can see the child's face and their color better than with a mask. But you're going to be limited with a nasal cannula on how many liters you can actually be delivering continuously via that route. And lastly, I don't have it on this slide either, but there's croupettes, also called mist tents. They're not really used all that much more. They're scary. They're enclosed around the child. They can be cold and wet due to the humidification of the air. And then when you open and close the tent, you lose a lot of oxygen that's being contained in that small area. So I don't know how often you'll see them necessarily anymore, but you certainly might in some instances. So let's talk about oxygen saturation here a little bit. Hopefully by now you recognize, just one second. Oxygen saturation, hopefully by now you recognize that pulse oximetry is measuring the arterial oxygen saturation in the blood. Oxygen saturation is the percentage of hemoglobin that is carrying the full component of oxygen molecules. So 100% equals completely saturated. Um, your normal range, we all are striving for the 100%, but anything above 95% is reasonable for children. And also keep in mind, if you do have a pulse oximetry probe on a child, just like if you were to have one on an adult, you want to watch for motion artifacts, watching for it in case it gets displaced or starts to fall off or is laying somewhere in the bed sheets and covers. Obviously, those are gonna set off your alarms right away, but also always want to just do some troubleshooting before you come to any conclusions with oxygen saturation, just making sure that the result that you're documenting is indeed a reliable result and makes sense given the appearance of the child and the other assessment findings that you have. Pulse oximetry, 3 potential reasons for false readings: abnormal hemoglobin value, decreased peripheral perfusion, issues with ambient light. If you don't have a wrap around the probe, that can give you a artificial or false reading. Motion artifacts, like I just mentioned, and skin breakdown. Those would be some possible reasons for some unreassuring readings. Review the procedure for pulse oximetry. That's going to be on page 844 in your textbook. The sensor can be placed on the finger, the toe, even the earlobe is a possibility. You want to avoid any areas where there's an IV running or blood pressure cuff. You want to try and avoid in kids, if it's a young female child with fingernail polish, if you can go to a fingernail that doesn't have polish on it, that's better. But of course, we all know that you can read oximetry through a painted nail. It just may not be as reliable. Many times, if it's a continuous probe, it's wrapped and covered too tightly. So you want to make sure that you're checking the circulation of that finger, or that toe, or that earlobe, at least with your hourly rounding to make sure that the circulation is appropriate and it's not on too tight. An opaque shield like black Coban can be used to shield the light from the pulse oximetry probe itself. If you're doing some checks, you want to make sure that you're checking as often as possible. This slide here says every 2 hours, but you want to make sure that it's still maintaining the integrity of the adequate reading. What's considered abnormal for a child? Like I mentioned, anything less than 95%. Now, keep in mind, there are some children that do have chronic respiratory conditions, and so their baseline pulse oximetry might be 94%. That might be as good as it gets for them, particularly if they have a congenital heart problem or a chronic respiratory condition like cystic fibrosis or something from a pulmonary perspective. Their baseline might be 95%. And so it's always good to look back in the medical history, ask the provider, ask the parents and the caregivers if they know what the usual is for that child. And then from there, you can decipher what would be unusual or abnormal. Arterial blood gas sampling, we're looking at page 844 here again. If you do need to assist with arterial blood gas sampling, you want to position the child's wrist with the palm up. You don't want to hyperextend the wrist, just make it nice and as comfortable as possible for the child. You always want to make sure you, of course, stabilize that extremity. You don't want the child to be able to twist that lower arm or forearm or wrist, and you don't want to let them be able to jerk that wrist or arm away either. So you're going to need to maybe get some reinforcements and get some people to help reassure and hold the child. When you're holding the arm, you want to make sure that you tell the other staff or the parents, if they're helping, to not grip too tightly. Otherwise, that's going to occlude the arterial blood flow and compromise the sampling. The skin's going to be punctured at an angle of 15 to 45 degrees. When the needle's withdrawn, it's pulled out slowly so that there isn't an arterial spasm that can be painful. After the needle's withdrawn, you want to put some direct pressure at the site. You can put on a sterile gauze pad there for at least 5 minutes. If the analysis is not going to be done right away, or if you can't get the sample to the appropriate location quickly, you want to place it on ice, again, to maintain the integrity of the sample. And then when you're documenting, you always want to make sure that you note the puncture site, what the activity of the child was at the time. Were they laying or resting quietly? Were they very agitated and fearful and crying and flailing about? That's all going to help the interpretation of the arterial ABG's analysis. ABGs are used to establish the correlation of oxygenation with pulse oximetry readings. It's also used to help monitor a child's acid-base balance. Usually, respiratory therapy is the one that gathers the sample, although it could be a neonatologist or an intensivist, like a pediatric hospitalist, for example, or a pediatrician. The preferred site is the radial artery. If they're having trouble accessing that access point, they could go with the brachial artery as well as a alternative. All right, a little bit about trachs and trach cares. You want to keep at the bedside an extra ET tube of the same size, or maybe even slightly smaller in case you need it. What should you avoid in having in reach of the child due to risk of aspiration? You want to avoid, of course, any small toys, any toys with small parts that can come off or get displaced and get placed down into the trach where, of course, it doesn't belong. You want to avoid any powders or any aerosols around the child that has a trach. And when you are doing trach cares, it's nice if you can have another nurse to help, especially when you're going to change the ties of the trach. If you don't have an extra set of hands, maybe the parent or the caregiver can be that assistance to you. It's not that to say that it's not possible to do it by yourself, but it's nice if you can have at least one helper there with you to kind of manage everything that's going on. Recommendations at home, educate the parents early, have them do return demonstrations for you so you can make sure that they understand the information and that they can return demonstrate what they're going to be doing with the child and for the child at home. Advise them or encourage them to get CPR if they haven't already. The child should avoid showers and mists, but baths are safe. And home health care can be especially helpful, particularly in the beginning. If this is a new intervention for the child, home health care can come in and do some checkups, do further education, make sure everything's going okay from that standpoint. The suctioning procedure, size and length considerations. Our range is usually between 5 and 14 French, half the diameter of the inner trach tube. The amount of suction is going to vary by age. So when we look at neonates and infants, we're suctioning between 60 and 80 millimeters of mercury. For children, between 80 and 100, and for adolescents, between 80 and 120. Physician orders or provider orders will often tell you how far down to go with your suctioning in terms of centimeters. Using saline to thin secretions is generally not recommended. They've found that it has a link to decreasing oxygen saturation readings. When you are suctioning, you want to limit your suctioning time to less than 5 seconds. You also want to have oxygen ready so that you can administer that supplemental oxygen between suction passings or passes. And you only suction on the way out, not as you're inserting the suction catheter. We usually recommend avoiding a scheduled suctioning time regimen. We only advise suctioning as needed, same as with adults. It's a sterile procedure in the hospital. However, we usually allow caregivers and parents to use a clean procedure at home with their sterile suction catheters, unless for some reason they're advised to use a sterile procedure. They usually can get by with just a clean procedure at home. And your assessments before and after suctioning, lung sounds, the quality and the quantity of secretions, the child's respiratory rate and efforts, and then also the pulse oximetry before, during, and after. Here's a question for you. What is appropriate to include in the care plan for a family of a child with a tracheostomy? I'll let you read through those options here and maybe decide as a class or with your neighbor what you think the answer might be. Okay, hopefully you picked A. Suctioning is typically just done as needed, PRN. You wouldn't want to pick B because we try and stay away from any powders or aerosols around the stoma. We don't want to have her at that risk of aspiration or any kind of accidents that way. Suctioning, you want to limit your insertion time to less than 5 seconds. 30 seconds would be way too long. And then hygiene should include bathing and not showers. So that's why you wouldn't pick D. Here's another one. How should pulse oximetry be explained to a preschool child? So think about the developmental level of the child, what's going to be appropriate, something that he or she will understand. Look at these different options and pick which one you think is appropriate. Okay, well, hopefully you picked A. That goes on the finger or foot and doesn't hurt. Not that these other options are necessarily going to be understood by the preschooler either, but B is incorrect. It is not more accurate than capnography. C is incorrect. It is not much better than arterial blood gases. And D is incorrect because it provides continuous measurements of oxygen saturation. The nurse must suction a child with a tracheostomy. Intervention should include which of the following? Take a look at your options there. And hopefully you pick C. Each pass of the suction catheter should take no longer than 5 seconds. A is an incorrect answer because if the child could actually cough, they could maybe raise their secretions and maybe even not even need to be suctioned. So if they're coughing and able to move their own secretions, we don't want to add that intervention if we don't need to. Hence the reason we only suction PRN. But if the child has a really good productive cough, they might just be able to be triggered or elicited to cough on their own and get those secretions moved out. You want to select a catheter with a diameter that is 1/2 as large as the diameter of the tube. So B is an incorrect answer there. And then D, you don't need to allow the child to rest. Well, you need to let the child rest after each attempt, not after every 5 times the suction catheter is passed. And usually about 30 to 60 seconds after each pass is sufficient. Nursing considerations related to the administration of oxygen to an infant include, I'll let you look those over. Okay, so hopefully you picked C to ensure uninterrupted delivery of the appropriate oxygen concentration. Humidified oxygen is always humidified, so it's not whether or not the infant can tolerate it, it's always humidified. B, assess the infant to determine how much oxygen should be given. Um, you need to have a prescription for how much oxygen should be given. The exception to that is if you have a protocol or a prescription for a titration of oxygen. So, for example, keep pulse oximetry readings above 95%. If you have something like that, then you can determine how much oxygen should be administered. Otherwise, it'd be a prescription that you're following specifically. And then direct the oxygen flow so that it blows directly into the infant's face. It shouldn't directly blow into the face. That's going to be very irritating for the child. It's going to dry out the eyes. So not your answer there. C is your answer. Okay, and last question here. Which nursing action is the most appropriate when applying a face mask to a child for oxygen therapy? I'll let you read those over. Okay, and hopefully you pick B. You want to make sure that you have a mask that actually fits properly. You don't want a mask that's too big, that's going to be infringing on the child's eyes and making them very nervous because it's pretty much covering half of their face. You want to make sure that the mask isn't too small either, because that's going to be uncomfortable for the child and it's not going to deliver the oxygen to the nares into the mouth appropriately. So you want it to be comfortable, and part of that comfort is going to be selecting the right size. Keeping the child warm isn't really going to be an issue if you're delivering oxygen via face mask, because that's just a very localized administration of oxygen to that part of the child. It's not, they're not in a mist tent, for example, where it does tend to get chilly via the humidified air. And remove the mask for 5 minutes every hour. Oxygen therapy isn't routinely removed. There's a reason why it's necessary, and so it tends to be more continuous than intermittent. And so let's see, A is incorrect because the flow rate should be at least 6 liters per minute. Again, that's to prevent the rebreathing of exhaled carbon dioxide on the part of the child. Okay, I'm going to round out this integrity with a YouTube video. And what you're going to see here is a series of pediatric patients that have variations in their respiratory status. I want you to start looking, watching some of the signs that these kids will have that are clearly exhibiting respiratory compromise. So look for suprasternal retractions, subcostal retractions, stridor, and remember that stridor is that constriction of the upper airways, head bobbing, nasal flaring, tachypnea, coughing, grunting. You should be able to recognize all of these signs of respiratory distress in the child. And hopefully as you watch each one of these video clips, you'll be able to pick them out and say, hey, I know what that is, or hey, I know what that is. I've seen that before. I've heard that before. That's very, very important. And hopefully you're to that point, or feeling like you're at that point where you're getting more comfortable with identifying these features. So I'll go ahead and play this video, and when it's done, that'll be the conclusion of this recording. All right, that's all I have for you. Thank you for your attention. Bye bye.